Hello and welcome to INGSA's Horizon series, our new interview series that aims to gain insights from leading experts at the Science Society Policy Nexus and how science advice is being utilized to address the current global challenges, as well as how they can be further leveraged to solve humanity's most pressing issues. And today, our theme is global mental health. I'm Abhi Veerakumarasivam, the Dean of the School of Medical and Life Sciences at Sunway University Malaysia, and I'm the chair of the INGSA-Asia. And with me today is Professor Dr. Vikram Patel, the Pershing Square Professor of Global Health at the Department of Global Health and Social Medicine at Harvard Medical School. Vikram is an honorary professor at the London School of Hygiene and Tropical Medicine, where he co-founded the Center for Global Mental Health in 2008, and is also co-founder of the world-famous Sangat, an Indian NGO which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008, as well as the WHO Public Health Champion of India Award in 2016. Professor Vikram's extensive work on the burden of mental disorders, the association with poverty and social disadvantage, and the use of community resources for the delivery of interventions for the prevention and treatment has been globally recognized. And he was even listed in the Time magazine's 100 Most Influential Persons of the Year in 2015. Thank you, Vikram, for making time for this despite your hectic schedule. So let's start with first talking about COVID-19. I guess we can't escape. And obviously the pandemic has evidently had a devastating impact on the mental health of people around the world. So what are some potential gaps that you have begin to observe emerging, especially in the context of our current mental health systems? And what have been some of the new initiatives that you have seen around the world that is actually being done to bridge these gaps? Okay.
So, Abhi, first of all, thank you very much for talking to me today about this extremely important subject. I think the first thing to say is that in many parts of the world, in many countries, for the first time, there has been a recognition that mental health at a population level is of great concern. This is because in most countries, COVID has appeared in these acute phases where, for example, in India in recent months, but in many other parts of the world at various times over the last 18 months, there have been situations that come very close to what I would call a humanitarian crisis. For example, where state systems for healthcare have virtually collapsed. And there has been enormous amounts of loss, fear, grief, and what I would call actually, when you put that all together, very high levels of trauma that you associate with humanitarian crises. And so it isn't surprising, as you see in any other humanitarian crisis, that there's been an increase in the level of distress experienced at the population level, and therefore also an increase in the numbers of individuals who have developed clinically significant mental health problems. Now, as a consequence, we now often hear even policymakers saying there are multiple epidemics that the world is facing right now. And by that, they really are referring to not just the epidemic of COVID-19 in all its various waves, but what people refer to also as the epidemic of mental health problems. So if there is one really important moment, historic moment, for the mental health landscapes of all these different countries to be reformed, it is now, when for the first time, both at the level of policymakers as well as the broader population, there is an acknowledgement that mental health is a critically important health asset for all people, and that this has been gravely injured during these last 18 months. Now, in terms of obviously, if it's an opportunity, how has that opportunity been taken up? First of all, it's important to recognize that before the pandemic, the overwhelming majority of mental health care systems at country level were underperforming. In fact, I would say when it comes to mental health, all countries are developing in one way or the other, because every single country has gaps in its mental health care provision. Every country has large disparities, and I want to emphasize the disparities in mental health. In the same way that we've seen disparities in COVID-19, there are equally very important disparities when it comes to mental health. Vulnerable groups such as low-income populations, refugees, minority groups in certain countries, such as, for example, sexual minority groups, but also people who have suffered COVID, people who've had complicated COVID infections, particular subgroups in the population like women and young people, etc., are disproportionately affected by the social determinants that lead to poor mental health. So all countries were underperforming. And here is a unique opportunity for us to relook at the way mental health care has been organized and how it might be revised or reformed in the period going forward. One important innovation that I want to emphasize has occurred in the last 18 months is, of course, the broad acceptance of telemedicine. And mental health care, of course, is best suited for telemedicine because there are no procedures that you associate with many other branches of medicine. In mental health care, most mental health care involves a skilled provider listening, assessing, and providing specific skill-based information and advice to the individual. A lot of this can be done in the way you and I are talking right now. And the broad acceptance and the scaling up of telemedicine across many parts of the world, I believe, is a very important innovation, a very important advance in mental health care in terms of improving access to mental health care. That said, one must also be mindful that there are disparities in access to digital technologies, and those disparities, of course, will also therefore mean that certain groups of people will have better access to mental health care on digital platforms than others, and unfortunately, those disparities overlap with existing disparities. So low-income groups, for example, who already bear many other forms of disadvantage, also have less access to telemedicine.
Great. Thanks, Prof. Vikram. You are right. It's ironic that sometimes the solutions for one inequality might actually result in a different type of inequalities. But it's obviously heartening to hear that the pandemic, despite its devastating impact, has also transformed some of the challenges as an opportunity. And I hear very clearly that much of these socio-demographic disparities are not necessarily geographically defined. But having said that, with the shortage of mental health professionals, especially in many countries in the developing world, and the very high cost of mental health care, there has been discussions on the need to democratize mental health and to improve accessibility and affordability. And you've kind of mentioned, telemedicine as an opportunity. But building from your own experience in India and what you have achieved through some of your innovative interventions, such as the Healthy Active program in Goa to reduce cost-associated treatment gaps of depressive disorders, what does democratization of mental health mean? And how might we achieve it, particularly in low and middle income countries?
So for me, democratizing mental health is exactly the same as democratizing health more generally. Health is too important to be left to medical professionals or healthcare professionals. Health is something that is the most important asset that every single individual enjoys in their lifetime. Sadly, we only become aware of how important that asset is when our health is actually impaired. And this is equally true for mental health, maybe even more true because there's much less open acknowledgement of how valued an asset mental health is. So to me, democratizing mental health is simply about making mental health everybody's business, recognizing that there is no health without mental health and there is no well-being without mental health, all of which are assets that we openly embrace already. Now, for me, one of the most important observations has been that even in countries which are extremely well endowed with mental health professionals, consider the US, where I spend significant amounts of my time, where I actually am employed, which has 1,000 times more per capita mental health resources than virtually any other country in the world. Even in the US, there are very large unmet needs for mental health care. It's also important to point out that in spite of enormous amounts of money spent in the US and indeed in many other rich countries, wealthy countries, on mental health care, over the last decade and a half, there has been no real measurable impact of this investment. For example, in reducing the prevalence of mental health problems or the incidence of mental health problems. In many, many wealthy countries, in fact, some of the metrics used to assess the population burden of mental health problems are getting worse. In the US, for example, suicide mortality rates are rising, especially in young people. And actually, this is true in many countries of the world. You will also find the numbers of people with serious mental illness who are homeless or who are unemployed or who are in prison is also rising in many countries. So the first thing we need to do is to recognize that whereas mental health care is extremely important for people with serious mental health problems, it is not the only solution to the population burden of mental health problems. We have to look beyond, no matter how wealthy or resourced a country is. This is true of every country in the world. Now, in low resource countries, like, for example, in sub-Saharan Africa or in India, and most of Asia, actually, I would say, which have very few mental health professionals, we have to rely on resources that are widely available in the community for health action. And I've been very inspired by the work that's been done in other areas of global health, such as maternal and child health, where community health workers, for example, have been deployed to deliver essential maternal and child health care tasks, particularly in those communities or contexts where there are few medical specialists for maternal and child health. And very robust scientific experiments, implementation trials have shown that these approaches are very effective in reducing maternal mortality, newborn and child mortality, improving the coverage of vaccination, etc., etc. So what my work has really been in India has really embraced this idea of task sharing to community health workers or other widely available human resources to actually train them to deliver mental health interventions. Obviously, in doing that, we also have to design mental health interventions that are relatively brief, that are relatively simple to learn, but are also mechanistically sound. That is to say that they are targeting recognized mechanisms of mental health problems, and then demonstrate that these approaches are clinically effective. Of course, they would be cost effective because we're really using low cost human resources, but clinical effectiveness is the most important outcome really initially. And that's the work that I've been doing for the last 10 or 15 years. I work across the board of mental health conditions, not just depression, but also I work both in prevention, for example, how we can use community resources to prevent mental health problems in children and young people, as well as for serious mental disorders, such as people who are living with schizophrenia or families where there is a member who is suffering from dementia.
Wow. It's really quite interesting that you mentioned about making sure that these interventions are brief, simple, but being mechanistic sound, and the fact that just having resources alone is not necessarily a predictor of impact. And it's true when you see about, maybe it's because of the availability of the data, but much of the statistics on the widespread impact of mental health shows that 1 in 3 or 1 in 4 individuals in high income countries are suffering from significant increase in stress, anxiety, and sadness. But when talking about inequalities in healthcare, be it maternal mortality, non-communicable disease-associated premature deaths, and life expectancies, much of the conversation that we hear that's in the literature tends to revolve around the inequalities that exist in the less developed or developing countries. And really, we are starting to hear, and especially in 2020, there was a lot of discussion on a need to decolonize global health. So first of all, maybe could you explain what does this mean, decolonizing global health? And what are your general thoughts on this?
Well, to first of all understand the current concerns about the northern, as it were, the control that wealthy countries, their institutions, their scientists, their funding agencies have on global health, one has to really backtrack a little bit historically about where global health came from. Global health is only the latest avatar of what historically we referred to as initially tropical medicine and hygiene. Then it morphed into international health, and now we have what we call global health. It's important to remember that the origins of global health, therefore, are rooted in colonialism to begin with. Because tropical medicine was a discipline of medicine that was created in the schools of public health and tropical medicine of the nations that colonized Africa and Asia, and Latin America, actually, but particularly Africa and Asia, and where the armies and the administrators who came from the colonizing countries found themselves in these tropical zones in which they were exposed to a whole range of infectious, parasitic, and other diseases that are dominant in these parts of the world. And so this was very much a self-serving agenda. It was really as part of the mission of perpetuating colonial rule. Pretty dark history. In the post-colonial era, tropical medicine continued in that particular avatar, but gradually morphed into international health to recognize that actually it wasn't just infectious diseases that were very important. There was, of course, they continue to be very important, as we've seen with COVID-19, but people in so-called tropical countries also suffered from other health conditions no different to people in wealthy countries. You know, diabetes, heart disease, injuries, and mental illness more recently has been recognized. So it morphed from tropical medicine to international health, which also began to embrace broader public health factors like social determinants of health, health inequalities, and so on. But international health was still heavily dominated by institutions in the global north. It was still very similar to tropical medicine in terms of where the power lay, in terms of intellectual capital, as well as, of course, financial capital. The global health was really intended, in my view, to upend that, because the definition of global health is not about the health of peoples in less resource countries. The definition of global health captures health inequalities at its heart. And health inequalities are not just between developed and developing countries, but also within every country. And we touched on this a little earlier. No country in the world, no country has eradicated health inequalities. The size of those inequalities may vary from one place to another, but every country in the world has disparities. And this is especially true for mental health, but also, actually, to be honest, Abhi, for many other health outcomes as well. So one would have thought, when that happened, that schools of global health would begin to be just as interested in the disparities in their own countries as they were in the disparities between countries. I believe the decolonizing global health movement has really been, has emerged because that has not really become evident in the way global health practices its field today. Unfortunately, most global health practice is still the same as its previous avatars of tropical medicine, international health, where essentially it's wealthy institutions in the global north setting the agenda, getting the money, and controlling the intellectual capital of researching populations in less wealthy countries. Where I do see global health being decolonized is in those countries of the world that have acquired greater intellectual and financial capital of their own. For example, India and China and many Latin American countries. In fact, I'd say these middle-income countries have been able to rebalance the power. Where I see the old-fashioned global health influences continuing to be very dominant is in sub-Saharan Africa, with the exception of South Africa. Many countries in sub-Saharan Africa and Southeast Asia would still continue to have relatively weaker academic systems, relatively weaker global public health and clinical medical research infrastructure, and also are relatively weak in local resources, financial resources to support research. Unfortunately, in these parts of the world, they continue to be, largely the agenda largely continues to be controlled by northern institutions. And I welcome the robust conversations that are happening about decolonizing global health. We do need to see a rebalancing of power. And at the same time, as I tell my students in Harvard Medical School who say, Vikram, I'd like to do a global health internship. Can I go to India? And I say, no. You don't need to go to India to learn global health. You can just go to that neighborhood in our cities, which are segregated and have very large proportions of low income and or African American and or Native American families. And you will find global health right in your own backyard. You don't have to get on a plane to study global health.
Great insights there, Vikram, and it's always quite interesting, right? Even when you talk about vaccine diplomacy, and even in the recent movement of donations of vaccines to much of the developing world, a lot of it is through the appreciation that nobody is going to be safe unless everyone is safe. And
Absolutely.
you can see a shift from, first of all, me first, or my country first, to realizing that, wait a minute, that can only happen after every country works. So I think that notion that global health um, can benefit and actually is needed in every country is really important. But you did bring up an additional point there about there are some countries, such as in the Southeast Asia and Sub-Saharan Africa, which may not have escaped that colonial mentality. But I think part of that is actually the resources and the limitations of these resources. So, and obviously they can't compete with the resources that are available to countries like India and China. And I guess even COVID-19 vaccine productions, I mean, you can already see the capacity differences between those two countries and Malaysia and other Southeast Asian countries. So my question, I guess, to you would be, what can these countries do to ensure that we really embrace global health without suffering from losing that control of our own intellectual capital?
Abhi, I'm going to say something provocative, Abhi. I think the first thing we need to do is we need to ourselves be confident in knowledge systems that come from the global south. I don't see enough South-South partnerships. Let's be honest. Whenever people in any low resource country or less resource country think about collaboration, how often do we first think about a collaboration with another southern partner? By south, I mean
Yeah.
socioeconomically south. I use that word to reflect the global north, global south. Actually, it doesn't come up very often. We don't even search for possible partners. Say, for example, if I was doing a program in India, do I first look at collaborators in sub-Saharan Africa? No, I usually do what all of us instinctively do, and we've been colonized in our minds. And so I would say, rather than try and look at our colleagues in wealthy countries and get them to change the way they think, we need to start with the way we think. We need to start acknowledging that there is enormous expertise in less wealthy countries and less resource parts of the world, and we need to look for those collaborators and institutions and try to establish partnerships that are south-south. So that's the first thing, decolonizing our own minds. Second, I think we need to be recognizing that many funding agencies are now directly supporting investigators as the lead investigators for research programs in low and middle income countries. The Wellcome Trust is a great example. The NIH is another great example. And there are many others. Many foundations, for example, directly fund researchers in low and middle income countries. What I would suggest is that once we've established a good partnership, once we have created the right combination of skills, we need to also have the right research questions. And I think we can refer both to local priority setting exercises, but also global priority setting. We need to embrace this idea that it's not just whatever I'm interested in that matters, but also what is actually the research priorities that have been set by our peers, the scientific community more broadly in my field. For example, in mental health, there are the grand challenges in global mental health that were set about 10 years ago. This was a research priority setting exercise led by the National Institute for Mental Health. About 40 research priorities were identified, and funders are now actively backing research that is aligned with those research priorities. That doesn't mean that investigator-led research is not important. It means that investigators are encouraged to lead research that is aligned with those priorities. And thirdly, of course, I would say investing in our own younger early career researchers. Those of us who are privileged to be senior faculty in universities in the Global South must spend time in investing, mentoring time, incorporating protected time for early career researchers, particularly in the clinical world, where doctors and nurses are being trained for clinical practice. Those who are interested for academic careers, that they have protected time with mentoring so they can learn research skills They can practice those research skills through mentored research so that they can emerge into becoming competitive researchers when they apply for grants.
Yeah, great. Thanks very much, Vikram. The next, I guess I want to segue into the science advice context, and you've already given some really good advice there. And I think if anyone's not convinced, I think in the last 20 minutes, you've made it so clear how important the fact that mental disorders are the leading contributor to global burden of years lived with the disabilities. But there's still a lot of stigma around it. And in many countries, there still doesn't appear as a top policy agenda. So even though you see stories and concerns and articles being written in mainstream media, and you rightfully say that more people are talking about mental health, but when you talk about policy agenda, especially now with the COVID-19 pandemic, a lot of it's economic recovery plan, it's herd immunity. We don't see this as a main policy agenda. So in terms of the role of science advice in the area of global health, do you think that this is because there remains significant gaps in knowledge, that we need more research in particular areas to be able to inform truly informed policy decisions? Or do we already have the necessary knowledge generated and synthesized, but we are limited by the potential barriers that impede the application, or as Sir Peter Gluckman will say, the brokerage of this knowledge into policy decisions? What are your thoughts on this?
Abhi, I would say we need both. I wouldn't really position these two options as being competing options. I would see them as complementary options. There is no question that, at least in the field of mental health, we have a long way to go in terms of generating new knowledge. Let's be absolutely blunt. Till today, in spite of billions of dollars of expenditure on mental health research, from much of it on the basic sciences, the molecular basis of mental health conditions and so on, the genetic basis and so on, we do not have a clear understanding of the pathogenesis of any single mental health condition. We have no idea of the mechanisms through which any mental health condition emerge, even today. And obviously, not having a mechanistic foundation to mental health conditions means that we can't really develop interventions either for their prevention or for their care that are likely to have sustained long-term benefits. So really, most interventions for mental health problems today are symptomatic. What the best we can do for most individuals, not for all, by the way. There are some really powerful curative interventions, but the truth is that for most mental health conditions, the best we currently have in our therapeutic armamentarium is either psychological treatments or medications for symptom management. Now, that said, we already know a lot that we can do to help improve the lives of people who are living with mental health problems. And not only do we have effective interventions, and I want to emphasize the big difference between mental health, I think, and most other areas of health is that our interventions are not just medicines. We need to recognize the incredible science of psychological interventions, which we don't do enough. Let's be honest, in most countries of the world, even the little mental health care that is available is dominated by medication. You ask most people with a mental health problem, what's their experience of going to a clinic? In most developing countries, it'll be, the doctor saw me, doctor, it's always a doctor, for about 5 or 10 minutes, maybe 15 minutes if I'm lucky, and wrote a prescription with 3 or 4 medicines and said, come back in a month. Yet, if you look at the actual science of mental health care, you will discover that medicines are only a small fraction of the overall intervention choices that are available. Psychological treatments are rarely available to most people. And of course, social interventions. Let's remember that mental health care is not just symptom management. It's also about taking care of the social conditions that often lead to poor mental health or sustain poor mental health. For example, I would say good quality housing, reducing the exposure to interpersonal violence are two examples of practical social interventions that are very powerful also for promoting mental health, preventing mental health problems, and helping people recover. So we have a lot of knowledge about what works, both in prevention and care. And I'd say it is just as important for us to translate that knowledge into practice. And there is a whole science agenda around that, what we today call implementation science. How do we put the knowledge we already have into practice? And I would say the kind of work that I do currently is mostly in that particular realm. How do we take clinically effective interventions or preventative interventions and scale them up in communities more broadly, regardless of what resources they may have in terms of the mental health care system?
Great. Thanks, Vikram. And finally, looking back at your amazing career evolution and the diverse roles you have played and continue to play, creating so much positive impact to thousands of lives. And I think I'm, confident just listening to you, and your conviction itself, brings so much hope. What is your advice to the young emerging researchers out there? And I think they will certainly, be very, very excited to hear that, one of the things that you mentioned just now about how we can improve our local ecosystems is by investing in them. So what's your message to these young emerging researchers out there who also aspire to expand their research and reach into the science public policy interface?
Well, the first thing to say is recognize that science alone does not impact policy. I mean, if it did, maybe many of the negative experiences we've had with COVID-19 would not have happened. Consider, for example, the well-established science that masking perhaps is the single most effective intervention. It's non-pharmacological. It has almost no cost attached to it, and it is more effective than anything else. And yet, we know the evidence of the extent to which masking has been translated into policy and practice. So science alone is not sufficient. Communicating science is a great skill and a talent, and I believe particularly those of us who are clinical scientists or public health scientists, but I'd say also the basic scientists, we need to master the art of communication. And this is not something we just learn on the job. There are actually now many opportunities for us to learn how to communicate through, for example, role models in our societies or more broadly internationally who have effectively communicated, engaged the public, engaged policymakers in communicating their research findings. I would strongly invest in that. And I would say, for example, those of us who are concerned with training researchers, we should make communicating science as important as the various experimental approaches and methodologies that we put so much emphasis on. Find mentors who have shown how they can not only do good science, but they can communicate it so that you can learn also directly from them. For me, also, engaging in the public policy interface is about also engaging and collaborating with people with a lived experience. Abhi, this is extremely important. I have been very inspired by, the HIV experience. Remember, we knew there were effective life-saving treatments for HIV disease way back in the late 1980s. But most people in the world with HIV only benefited from that knowledge in the early 2000s. For over a decade, countless millions of people whose lives could have been saved died because they did not have access to life-saving treatments. To me, it's the biggest scandal in global health. And of course, this led to the emergence of global health. And if you look at the story about why millions were allowed to die and what changed that, it was in fact partnerships between scientists and people living with HIV. And I'd say it's exactly the same kind of approach we need to have in every branch of medicine and public health, which is we partner with communities and in particular people with a lived experience, because they are the ones who are, as it were, the most powerful voices to communicate our science to policymakers. And finally, partner with people who are directly engaged with communication. The media, I do a lot of work with the media myself. I engage with media experts, with filmmakers and so on, because I believe that they have wonderful ways of communicating what is actually often quite boring for most ordinary people, like a 4,000-word article. I mean, seriously, very few people really read it. How do you convert that knowledge into something that is engaging for the broader public?
Thanks so much, Vikram. And I think your point about how we often negate the importance of understanding a factor called cultural acceptability, and you're absolutely right. And that's one of the main missions of INGSA, that we understand that science and evidence is really, really important in policies, but it's not the only determining factor, and there's so many different factors. And two key points: communication and partnerships, making sure that you have friends to advocate and really make that change. Thank you so much, Vikram, for spending time with us today. I know you are really, really, really busy, but I can assure you that we are extremely grateful for your really open sharing, and it's truly inspirational to have these valuable insights, and we hope that it's triggered everyone listening here to think about the role that they actually play, and hopefully try to actually make that difference. And as Vikram said, look for mentors. First of all, make sure that we fight that imposter syndrome that we have if you're coming from some of these lower resource settings, but more importantly, to work together. I'm sure everyone today watching would agree with me when I say that we've learned so much from you, Vikram, and hopefully we'll be able to apply those lessons in whatever capacity we have to continue to drive global health forward. Please continue inspiring, and I look forward to collaborating with you, together with INGSA. To everyone watching, thank you so much for joining us today. And if you'd like to learn more about INGSA or get involved in our program and activities, you can visit our website at www.ingsa.org. Thank you all once again, and we hope to see you at future events. Take care, stay safe, and stay connected. Thank you.